walk up and I'll bring the chair for you.
Movement. Grace. Control. For some, like prima ballerina Gazela Witkowski, a challenge, a skill to be mastered.
Big and strong.
For people with Huntington's disease, a memory of dreams no longer attainable.
I think a lot about my patients and how difficult the most basic things can be for them. Sometimes when I'm eating, I try to imagine what it's like for my Huntington's patients. It's hard to accept, really accept, that they're in danger just from eating, the very thing that nourishes us and keeps us alive. There are things I can do that make a real difference, reducing the danger, really improving the quality of their lives. It's hard to face alone, for them and for me. Even understanding the basic problem is complex.
It thickens your tea as well a little bit. It'd be easier to swallow.
Okay, can you take a little drink for me? Okay.
Swallowing problems are rarely a complaint at the time of diagnosis of the disease. It is of primary importance for the caregivers to be aware of the progressive potential for these difficulties. Some of the clinical indications of swallowing problems are coughing and choking at mealtime, chronic pulmonary congestion, poor chewing ability, regurgitation of food, refusal of certain foods, spitting of food, inability to swallow voluntarily, and a lack of or weakened cough reflex. These should lead the caregiver to seek out professional services. This is a normal swallow. You can see the 4 phases in the swallowing process, a combination of voluntary and involuntary movements. Let's slow it down. The oral preparatory phase is a voluntary movement beginning when food is placed in the mouth and chewed. The food is mixed with saliva in preparation to be swallowed. The teeth, tongue, lips, jaw, and cheeks are all used here. The second voluntary movement is the oral phase. The tongue gathers the food into a ball and moves it to the back of the throat, holding it against the hard palate until the swallow reflex begins. The pharyngeal phase, which is involuntary, begins as the food enters the pharynx. The pharynx contracts to help food travel down and the vocal cords close to protect against food entering the airway. The vocal cord's primary function is protection. Speech is secondary. This is why it's a speech-language pathologist whose assessment is essential when dealing with swallowing difficulties. The final, esophageal phase is also involuntary. The ring of muscles that make up the esophageal sphincter relax in preparation for the food to enter the esophagus. As food passes from the pharynx into the esophagus, muscle contractions take place to allow the food to travel through the esophagus and into the stomach. So, something that most of us don't even think about actually requires accurate coordination and timing of a complex series of muscular movements. Given the involuntary movements and decreased muscular control caused by Huntington's disease, it becomes immediately obvious why swallowing difficulties can be profound as the disease progresses. Appetite changes, memory changes, and changes in the thinking process also affect the swallow.
Great, it's all clear of food.
The most impaired stages for the advanced Huntington's patient seem to be the first 2, as the food is being prepared to be swallowed, the voluntary phases. Increased difficulty with tongue coordination and movement make it difficult to form the food into a ball and then position it correctly to trigger the swallow reflex. Food and fluids can enter the pharynx before protective mechanisms are in place. The entire timing of the swallow sequence is compromised. Not only is choking a possible result of these problems, but aspiration pneumonia can occur because of food particles entering the lungs past the unprotected airway.
You're okay now?
Because the act of swallowing involves many processes, it is important to obtain an assessment of the problem from many varied viewpoints.
Trilithon is the thing that seems to help him the most.
Physical difficulties, nutritional needs, cognitive status, psychological well-being are just 4 of the many considerations. When the hospital facility doesn't have access to a full assessment team, it is vital that at least an initial consultation with a speech-language pathologist be made.
Several levels, but is unable.
The longer a patient can be helped to maintain independent eating, the better for the patient's sense of self. Specialized feeding equipment, rimmed plates, plate guards, non-slip mats, scooper bowls, specialized forks, spoons, and cups can help greatly with independent eating skills. Eventually, the need to maintain adequate nutrition will outweigh the benefits of maintaining independent eating, and the very difficult decision to intervene must be made. Once a swallowing plan has been devised, it is extremely important not to change the management strategy without further consultation. Some basic procedures to follow include creating a calm and focused atmosphere. Minimize distractions. An upright position with head tilted slightly forward during mealtime can help with swallowing, and the patient should remain upright for 30 to 45 minutes afterwards to prevent regurgitation and subsequent aspiration. Modified seating may have been deemed necessary during the assessment. Be certain that the mouth is moist before beginning the meal. The food consistency is a very important consideration. Thicker, pudding-like items are often effective because they are easier to gather in the mouth, unlike liquids and thinner foods. Again, the consistency of many foods can be altered with thickening agents, such as Consistrite, especially helpful since thin liquids often pose the greatest threat to the swallowing-impaired individual. One of the things the assessment process discerns is the placement of food in the mouth to stimulate efficient swallowing. Generally, food can be placed in the middle of the tongue and a slight downward pressure with a spoon used to trigger the swallow reflex. Syringe and bolus feeding are never considered as acceptable feeding methods. Coughing should be encouraged. It is a natural protective mechanism when choking occurs. A swallowing plan greatly reduces the risk of problems that would call for the use of emergency procedures, such as the Heimlich maneuver or suctioning techniques. Meal times shouldn't be longer than 30 minutes. Fatigue and frustration can create an atmosphere where aspiration can occur. The mouth should be checked and cleared of any food residue after meals. Aspiration can occur long after mealtime if residue remains in the oral cavity.
You're really hungry.
I was terribly nervous when I first started feeding my Huntington's patients. Frightened, really. And my patients were even more frightened. They were voraciously hungry. The greatest thing about learning how to deal with the feeding and swallowing problems is watching my patients relax and enjoy their food again. It's incredible, giving someone that feeling of security.
It is often the nurse who first notices swallowing difficulties and requests the process of assessment.
The expected outcomes are that he
As
will
part
be
of the
able to
assessment
feed
team,
back
the
food,
nurse can provide an
supply,
accurate history of the
and,
patient's eating habits and difficulties.
his weight
And of course, it is the nurse who most often carries out the management plan.
a little bit more.
in terms of his communication, I
A